Hey Frank, how you doing?
I'm good. How are you?
Good, good. Hey, it's Dave and Frank. We're here with the hybrid treatment approach to lower back pain. This is basically based on a couple articles. One was from Paul Hodges. He did a collaborative article in the JOSPT. They had a 2019 edition, which basically summarized, a lot of the different concepts and aspects about lower back pain and treatment. And it tried to point what was current in research, basically from different fields. This article based on kind of a hybrid approach, integrating multiple mechanisms. So we're going to go over a little bit of that, and then also kind of, bring in some outside material as well. Also be sure to include some of the material from, manual therapy mechanisms we spoke about in the prior presentation. Some of our learning objectives here are going to be understanding Hodge's stratification method. We're going to also go back over at Joe Bolowski's, manual therapy, neurophysiological mechanisms. We're going to integrate manual therapy and dry needling into this concept and see kind of where does dry needling kind of fit in the scope of orthopedic manual physical therapy. We're going to go back over again and define dry needling's mechanism and its niche within the motor control restoration system. We're going to talk about the start back tool a little bit as well. Again, you'll see we're going to kind of present some of the pros and cons of the start back tool and how it's used, and also look at applying a hybrid model to some patient cases.
So the big problem with low back pain is, this one size fits all uh, program. You know, y- Low back pain is a mixture of things. We've seen it in the clinic. There's all different types of tissues, psychological overlays, and social features that feed into it. And that really, yeah, there's a problem where there's no single mechanism that explains the majority of presentation. So Hodge's idea here is to try to find a way to integrate three things. He talks about the prognostic stratification with the start back tool. He talks about the mechanism-based subgrouping, and then finally tailored treatment. Um, and really helps us avoid two traps. One is the one size fits all protocol, and the other one is the technique driven thinking. So it's, hey, we're only thinking about just one kind of technique. So instead, we're going to identify the dominant mechanism, treat that, retest, and then choose the next step.
Yeah, it's kind of often the confusing thing in physical therapy is that, we have these different methods and we're trained in a certain way or we followed a certain school. And, to any follow one system, we generally leave some other things on the table. So it's really how can we kind of be aware of, just how all these different systems can help integrate to get the best possible treatment and the fullest view of the individual.
So before I mentioned that individual variation in low back pain, this kind of goes through a whole list of all the different things. Some people might be all biological, some people are going to be all psychological. Most of us, though, are probably going to be a mixture of all three of those. We all have social, psychological, and biological features that are playing a part.
Yeah, the biological features is kind of where, certainly is our domain of expertise. We want to be able to have strategies to work with the psychological and in the social domains. This is where we are in tissue pathology. So when we look at, manual therapy in this world or dry needling, we can think of even in the dry needling in particular, there's the local, physiological effects in the tissues that we are treating, which can be, initially we can needle and we can upramp the release of histamine, prostaglandin, and inflammatory mediators to get a rebound improvement in those areas. So we have tissue pathology and the biological factors then also go into the neurophysiological components, which we spoke about in the last one, which is more your pain neurobiology, that central peripheral sensitization and descending inhibitory control mechanisms. Certainly there's some autoimmune responses that they talk about with dry needling as well. That would be covered in there. And, we have those not only in the inflammatory response that generates the patient's pain, but in the needling response sometimes that can help modulate that pain. Certainly in changes in the brain structure and pathway. Brain imaging has really showed us kind of a bit, even like, the research study I thought was very interesting. We looked at Achilles tendinopathy and that people who kind of got almost 80% better with Achilles tendinopathy, but couldn't quite get that last bit, that a lot of it had to do with maybe some changes in the cortical brain map. That they saw that those individuals, that their brain map and the areas that fired to coordinate tone, the movement patterns was different from right leg to left leg. and that training the brain map and timing was the missing piece. And certainly with needling, for some individuals, we have the ability to modulate that descending inhibitory control that we saw in the last presentation. So, in its biological features, is needling comes and integrates with these different areas.
So as we mentioned, this tiered system, first we stratify the prognostic, or really it talks about it's the risk of developing chronic pain. So where do they fall in that low, medium, or high risk? And then let's identify the mechanisms. So this is, hey, let's not look at just one thing. Hey, we're not going to look at just McKenzie. We're not going to look at just treatment-based classifications. We're going to look across and figure out what's the mechanism, what type of pain is the driver, and then we're going to tailor that treatment for that.
Yeah, within there fits in our manual therapy techniques and dry needling. How much of this is sensitization? How much of this is this a mechanical thing where now my manual therapy treatment is more biomechanical than, I'm sorry, yeah, biomechanical than neurophysiological? And how do we integrate that with the movement science and patterns?
So the Start Back tool, if you guys haven't used it, um, is is a tool that looks, it's not 9 questions. And again, looks at low, medium, high risk of poor prognosis. It's used a lot in big systems to be able to identify patients who maybe have a high risk of poor prognosis. The low grouping, the low risk, typically it's minimal care. In the research, they talk about, hey, education to avoid bed rest and resuming normal activities. Medium is the kind of multimodal PT, but the question really is, what does that mean? There's not a whole lot of guidance in and of itself. And then the high is to make sure there's psychologically informed care. Hey, let's maybe pull in a mental health therapist as well as doing the other physical therapy modalities.
Yeah, that's where kind of, the idea of minimal care and saying, okay, does this person even need physical therapy? Would they do well just with some education and send them on their ways? That part never really settled very well with me because quite honestly, those are the individuals who probably have these low-grade biomechanical faults, whether it's an extension dysfunction, a flexion dysfunction, a joint subluxation, a movement pattern disorder, that'll do well with skilled therapy to address what is their driver so that that minimum care patient isn't a medium care patient, you know, 3 years from now as we get the breakdown. And I think it's consistent with looking at, hey, somebody has a back injury and you see changes in the multifidi firing pattern. And though the pain goes away, that reflexive pattern doesn't change. The delayed recruitment or decreased recruitment continues on. And then there's segmental consequences of, again, muscle atrophy, fatty infiltrate, increased segmental loading, breakdown of that segment occurs. So that's where this minimal care thing, I'm always very apprehensive about saying, hey, this person doesn't need anything. I think we really need to clearly assess what is the thing that will maximally benefit this person. This person may not be the 12 visit patient that you're going to see, but 3 quality visits can make a meaningful change in this person's long-term outcome. So that's kind of where the minimal care thing, whenever I do this, it always just kind of gives me a bad kind of feeling in my gut.
So here's the tool. A couple, but most of them are kind of psychologically or emotionally involved. In the last 2 weeks, I've dressed more slowly than I would because of the back pain. I've only walked short distances. In general, I've not enjoyed all the things I used to enjoy. And then the last one is how bothersome are the symptoms, and you add them up out of 9.
Yeah, here's with my back pain spreading down my legs at some time in the last 2 weeks. Not in here does have the quality of pain. Did this back pain spread down my legs? Did it go to the foot? Was it lancinating? Was it callsalgic? Was it just a dull achiness that extended at my knee? So, here we're not really getting in the sense of, okay, coming up with a differential diagnosis with the start back tool. We're just seeing here every screen and we have a bunch of, okay, I didn't have these. It's just indicating that they may not need a lot of care. So that's kind of the differentiation with this. If we use the thing to start back as, oh, this dictates, oh, this person needs care. It's not really a great diagnostic tool for that. It's more for stratification of what's how prognostically, how will they do?
So if they're three or less, they become the low risk. Um, Four or more, then you look at two things: the sub score of questions 5 through 9. If they have three or less from that one, then they're medium, or more of questions 5 through 9, and they are the high risk.
So in some ways, I think this is almost very handy if you need to kind of justify. It's like, who's that person who is a high risk? This person is going to take a while to get better. They have a lot of fear avoidance beliefs, some kinesiophobia. They're going to need a more robust or, rounded treatment pattern once you may be in that four or more category. So it's going to be a bit more multimodal. And key thing here is remember that this start back tool, those questions, it's really a prognostic tool, not a diagnostic tool or a mechanistic tool. It's going to basically predict risks of persistent disability, not underlining cause or mechanism of pain. So this is not a tool that you're going to use to say this person, will do well with dry needling or do well with manual therapy or not, or with an, movement-based rehabilitation program. Again, it doesn't differentiate, as we saw, nociceptive, neuropathic, or central sensitization pains, or movement control, or versus psychological dominance. So most of the people, they're saying medium risk. I'm going to say low risk and medium risk, but the result's still in that clinical mechanism based. We want some type of, evaluation diagnostic procedure to determine what is the most likely cause of this person's problem. Again, here we're going to see that, one of the start back tool things about it's the psychosocial overweighting, where again, 5 of the 9 questions relate to the psychological constructs. This weighting may overclassify physically dominant cases as high risk because this person is in an acute case and you catch them at that glimpse, but maybe in 2 weeks, this person is no longer in that high resource needing category. So in some ways, you may get overweighted in there because of the phase of injury you're catching this person in, acute versus subacute versus chronic. They may weight differently depending on kind of where you're catching them. Yeah, the tool doesn't tell you what to do or how much care intensive to provide. For example, it doesn't distinguish whether it's use manual therapy, dry needling, or motor control exercises. It doesn't offer guidance on the progression or treatment sequencing as well. Again, that idea too is, again, one step from the British Journal of Medicine is that, found that, some clinicians misinterpreted all medium risk as an invitation to use generic exercises rather than a tailored treatment. So were they just saying, oh, you're medium risk, so let's go ahead and do a general exercise program versus trying to subclassify what would this patient most benefit from? And we also talked about the idea of that static snapshot of, okay, this is an acute patient. They may present more as the high category, whereas, okay, you do 3 treatment sessions or 2 treatment sessions, get some things sorted out for this individual. And now, they're looking more like a medium classification. So, this is a snapshot in time in that individual. So many times it's really going to be looking at how do they then progress. So that high risk category patient may not be a high risk person in 3 sessions. Again, this really accounts for no response to motor coordination or timing deficits, multifidus inhibition, lumbopelvic control, or load transfer issues. The Startback tool really doesn't get a sense of, hey, this person is going to respond really well to correcting their flexion-based pattern in the lumbar spine. And again, it doesn't really account for the neurophysiological modulation or treatment responses. This is not going to predict whether this person is going to be a good candidate or a poor candidate for manual therapy or dry needling. You're a high risk person may respond really, really well with dry needling for the myriad of neurophysiological pain modulatory components that it has. So it in some ways it's not really going to help you in predicting this person. Now, certainly they're a high risk person. Many times those people are an all hands on deck approach. I want my full toolbox available to me to modulate it, especially if there's a high level of central sensitization I want my tools that are going to kind of help me, interact in the central nervous system the best. So again, not that I'm not going to do dry needling with other cases, but dry needling manual therapy would certainly be appropriate for your high risk individuals. And risk I don't like with this is that oversimplification system that low risk needs advice only was the classic one. They said this person is just basically patient education. I don't think that's fair. I don't think our research shows that. I think those are the individuals that you can really make a huge difference by giving them the right information. I joke with some of my older patients based on a funny thing a physician once said is that, hey, sometimes, yeah, you had a good run. People were able to cheat for a long period of time with what they did posturally, biomechanically, where they are. But, it's this point now, they're doing something which is creating stress or undue tissue tension. We need to, in that individual, it may be advice, but they need a quality assessment to say, yeah, this is the cause of your extension-based lower back pain. It's the way you're bending, it's the way you're reaching, it's how you're sitting, it's your daily pattern. Maybe it's your exercise program that, yeah, it worked for 10 years, but it doesn't work anymore. And we need to kind of make those subtle changes. So the low risk advice only one, again, I'm very apprehensive about doing that given body of knowledge and quality of care that we provide. Some of the pros, we have a valid, efficient triaging for subcategorization. Cons, this is a non mechanism specific. We have no idea what's causing the pain. And use this to set direction, maybe not destination. You can kind of, classify this person's not going to need a great deal of resources. Or again, you can kind of qualify that, yeah, this is an all hands on deck approach. I know that this person is high risk for chronic pain. I need to make sure I'm managing and looking at all the different buckets that may be driving this, not just a select few.
So you think about subgrouping, this is kind of a hodgepodge of a bunch of different things. And this is where that, hey, I think we talk about having a lot of tools in the toolbox and not following one specific brand is good. So, the different types of subgrouping are, hey, people that would improve with motor control training, the whole treatment-based classification that kind of breaks people into either specific exercise, manipulation, stabilization, or traction subgroups, the McKenzie method of mechanical diagnosis and treatment, the movement system impairment from Shirley Sauerman, and then the cognitive functional therapy. It's kind of I'd say maybe a big spectrum of, hey, very mechanistic to, hey, some of the cognitive functional things is more pain, it's more just pain science. And I think the big takeaway that I think you and I do is, hey, we're going to take things from all of this. And this article talks about, rather than worrying about necessarily these things, let's look at the mechanism of pain first.
Yeah, I mean, a couple examples just drawing from this. Okay, the movement system impairments. Here we're looking at a system kind of represented by Shirley Sauerman, where they looked at, okay, do I have muscles that are being over lengthened or muscles that are hypertonic and limiting range of motion? So, the manual therapy or dry needling techniques in particular, let's talk about them, is that, yeah, when you're needling a muscle which is carrying, a little bit of increased tone, partially you're going to be using that as a neural reset. Okay, maybe that muscle is hypertonic, like classical upper trap or levator scapulae. Maybe there's some histamine, prostaglandin, substance P, accumulating from that constant trigger point that's being created from that hypertonic levator scapulae, let's say, in an inferiorly rotated or depressed scapula. Needling increased local blood flow to that muscle to wash out some of the histamine, prostaglandin, kind of a neural reset. I often tell patients it's kind of like blowing the fuse box in the system. You needle it, you kind of short out the fuse box for a little bit and allow the neural system to reset to create this window for correction of the faulty posture. I think you'll also find that needling some of the inhibited or over lengthened muscles too has a nice either pain modulatory approach or even facilitatory approach for a muscle that may have been inhibited for a while. And let's say, for an example, multifidi there, or is it going to be a gluteal muscle? So, dry needling, even integrating electric stim has a lot of neural input to multiple centers, spinal level, descending inhibitory control. So in the movement impairment system where you're looking at these patterns and you can also take it another step and look at the upper cross, lower cross syndromes that they talk about of what is facilitated and inhibited. Think about how dry needling integrates within that pathway. It fits within these systems, you know. And certainly you could easily look at the McKenzie system or, some of the other classification systems, with the treatment-based classifications and say, hey, it fits within these and these patterns. So how do I facilitate a muscle? How do I inhibit a hypertonic system or system that should is like it should be when it should be relaxing, it's not. How do I facilitate this muscle's ability to relax in its normal state?
A great example of, in the treatment-based classification would be a patient who kind of maybe classically fits that stabilization classification. But then, hey, their lumbar multifidus is inhibited. Their transverse abdominis is, doesn't have any more, doesn't have any feed forward timing. So can you then use some needling to go after those two things and then follow that up with some motor control training?
Tier two, it's a mechanism-based subgroups. The medium risk assessment, the dominant drivers are going to be your nociceptive movement-related pains, your central sensitization, to some degree psychosocial, your neuropathic pains. I mean, you're looking at your classic musculoskeletal drivers, your nociceptive pain. That can also be, you think of also like somatic pain as another term that's used for that. That is your lower back pain patient. That is your, nociceptive pain comes from soft tissues. Neuropathic pain comes from neuropathic tissue. Central sensitization is going to be more in the category of this is more of a central neural driver, where the neural system itself is ramped up either at the dorsal horn, with now you're getting increased collateral recruitment of what is normal input is now being perceived as being pain, or you have it being up-ramped somewhere within the central nervous system. That can be upregulated as the signal is transferred onward and upward. It could be that you have decreased descending inhibitory inhibition of the pain or the noxious signal. And there's things. So as we do this and we think about, needling, you see in the chart that we showed in the prior, you know, first presentation, you can see as we're in this medium subgroup, that's where we're kind of using needling or dry needling in this area to modulate pain and to create a window of opportunity to down ramp it. I will admit, I think out of all of them, neuropathic pain is the trickiest one because it's usually caused by inflammation or mechanical compression of neural tissue. Usually you think of your posterior lateral disc herniation or inflammation around that or compression on the dorsal root ganglion. That type of pain pattern, sometimes your needling interventions can downregulate it centrally, but that's a pretty strong pain. So, if they're getting neuropathic pain, not that it can't help, but sometimes that's a little trickier one to do. So there's a bigger toolbox technique. Not that I wouldn't do it, but just as I look at these three pain patterns, I would think that, yeah, my nociceptive driven pain and my centrally driven pain would probably be the ones that would probably get the biggest impact. But my neuropathic driven pain, I'm probably going to be using this as an adjunct to other tools, as I would with the other two ones. Go down.
So both manual therapy and dry needling in this hybrid model can be plugged in and should be plugged in. They act as modulators to reduce pain, normalize tone, enhance the proprioception, and restore that motor drive. They decrease that inhibition, long enough to create a window for some skill retraining, motor control work, and kind of rewriting that nervous system a bit.
Pathoanatomical and biomechanical models. Pathoanatomical models, these are tissue-based models. You know, it's clear, but sometimes overly medicalized. As you often, hear them say is that, okay, you can't really determine what the lower back pain is from. I think you can come up with a pathoanatomical diagnosis. You can't do it 100% of the time, but you can get pretty close. So the pathoanatomical model relies on really clearing, okay, this is a posterior lateral disc herniation. This is a grade 2 strain of the biceps femoris. This is a, tear of the medial meniscus type of things. Biomechanical model, much like what Shirley Sauerman has proposed and some others, is movement based. It's useful, but it can be also incomplete. This is that model like your Peter O'Sullivan, you have a flexion based or extension based pain mechanism. So though the flexion-based model, a disc herniation certainly could be one of them, but it could be an expanded neutral zone of a facet joint. It could be other pain drivers. It could be, improper stability of the multifidi or the muscular system during forward flexion. It could be a hypertonicity of the longissimus iliocostalis, an overactivation of those muscles through the forward flexion cycle. So biomechanical model, we'll talk more about movement-based patterns, and I think it's very, very useful to understand and have them in their pocket. I think needling aligns really, really well to some degree with the biomechanical model and those great models that are out there because you can kind of already know from pattern recognition, hey, this is which muscles are inhibited, which muscles are facilitated. Those are going to be great targets for your manual therapy, your dry needling. Certainly a hybrid approach. We're looking for something that integrates multiple models. And the hybrid model was really kind of proposed even by Hodges a while back and some other people. And it's called really the clinical reasoning model. It's really about using your clinical reasoning skills and your knowledge of the multiple models to come up with what is the best approach for the patient that is presented to you. So I really always like the idea that clinical reasoning model that integrates multiple different pathways from treatment-based classification to the biomechanical model to pathoanatomical models.
All right, so you think about a case here, 35-year-old male with recurrent right low back pain, no radicular symptoms, and somatic referral into the buttocks. So right off the bat, I would say, hey, all right, there's not, neuropathic pain is not the primary mechanism. Likely it's going to be some nociceptive, and hey, we're not quite sure yet about the central sensitization. All right, you give him the start back tool, and he's at medium risk. Okay, well, where do you go from there? Um, all right, let's delve down in Hodges' funnel here, and find a likely movement control dysfunction. So, um, you know, is there some feed forward things that are not working well, which is causing this recurrent low back pain? Hey, there's something mechanical going on. He has it, it goes away, but it's still happening.
Yeah, that's what you're gonna look at it. And then your movement-based system, oops, we're gonna look at flexion patterns, we'll look at extension, rotation, your common things that you're gonna do first. Certainly we can, the nature of somatic referral or that nociceptive pain pattern is an important thing to understand there. Now, this 35-year-old male with recurrent right lower back pain, he could be coming in with somatic pain now. I always keep my mind open though that, hey, many times I see somebody come with somatic pain with no radicular symptoms, and then 3 days later, because of the inflammation around the nerve, they develop radicular symptoms. So these can be shifting cases, and I keep my mind open to that as I see it. And same thing too, as you often see somebody only has pins and needles down their foot because of maybe some neural compression with no local pain in the back. And when inflammation sets in or it becomes to a certain degree, they may develop back pain at a later point. So it's that idea that your patient can shift from being, somebody who has, nociceptive or somatic pain and then develop radicular pain, or you can see it go the other way as well. They can overlap and coexist.
So when we look at the literature, it's pretty clear that people with low back pain, especially persistent or recurrent low back pain, develop pretty clear and measurable changes in motor control. One of the big things you see is this multifidus, in particular lumbar multifidus inhibition. It can decrease in thickness, it can lose symmetry side to side, and it shows some delayed activation. Along with that, you can also have this delayed transverse abdominis activation. So, a feed forward deficit, not just with spinal tasks, but really, I'd say everyday, limb movements as well. Um, picking up your child, you're grabbing a cup of coffee from across the table. With that, movement variability can drop too, so that they're going to use more stiff strategies, co-contracting the erectors and the obliques to kind of protect the spine, which is going to overall increase compression and decrease adaptability. So compression across the joints is going to increase. In the subacute phase, it's going to turn into some reflex inhibition and atrophy, which will then progress in the chronic phase.
Yeah, so when you think about dry needling just within these phases, I mean, are we dry needling to put multifidi stimulus in there, maybe doing it with some NMES to kind of, stimulate the multifidi, but then also the kind of the brain pathway to the multifidi to create that, can we excite that feed forward mechanism that has the multifidi fire right before we do it? If you look at the other phase where we talked about longissimus costalis, and all the other muscles do different patterns. I think one of Hodge's studies that was in that 2019 publication, showed that okay, they looked at 17 different back pain patients, and they had 17 different muscle firing patterns with activities. So it's variable between individuals, but there are a couple that are kind of common. One would be overactivation, longissimus costalis, and also decreased, flexion relaxation phenomenon. We bend all the way forward to kind of lean down. The erectors spinae actually have really, and those erectors have very low tone at the very end range. You're kind of hanging from the ligaments. Though individuals with back pain tend to carry much higher tone and then have pain coming back out and be weaker coming out. So we think of a dry needling intervention to kind of regulate either neuromuscular tone or modulate pain. Here we have a deep activation pattern, maybe for multifidi. Maybe we're looking to reset some of the hypertonicity that may be going in or that patterning in the longissimus iliacostalis or even internal external obliques.
As that acute phase transitions to a chronic phase, whether or not, um, this can be, I'd say in my mind, almost two things. One is, hey, that they have pain that lasts from acute, they don't get any treatment that lasts to chronic. But this also could happen with if you have acute pain and then you don't fix this multifidus inhibition. Hey, pain goes away, but the firing patterns don't change. Now, over time, you're going to have decreased activity of the lumbar multifidus, and then eventually fibrosis and fatty infiltrates are going to set in, so that you can see on this picture here, you have fatty infiltrates, fatty tissue in the bulk of the erector spinae and the multifidus, which is then going to feed forward, and the erector spinae are going to be overactive, and then your cortical drive is going to decrease. So that gets into that diminished motor variability we talked about a minute ago. You get this corticomotor reorganization. The maps of the trunk become blurry and overlapping. Now all of a sudden they can't dissociate movements and segments like they could before, and coordination becomes less efficient. So again, you think about needling here, in the acute phase, hey, there's, the local sensitivity changes, descending inhibition changes. And then now in this chronic phase, it's really, hey, can we help to remap the cortical representation of the trunk in the brain? And can we increase that proprioceptive awareness and try to get some more activation of the multifidus to then follow it up with exercise to help to replace and rebuild that hypertrophy in the multifidi.
That's a big deal. And that's kind of where we think about where that needling target for stimulation is. Can we get this neural system to wind up? Because as we get into in grade one, certainly grade two, multifidi blow up like a balloon in the thoracolumbar fascia. And that balloon-like blowing up that we see here in grade one creates a lot of stability. It creates tensions the thoracolumbar fascia as it wraps around. It sets a stable base for TA in the deep system. So when we get this atrophy or this inhibition, we don't stabilize and blow it up. It's often kind of referred to kind of like, and you see those blow up things outside the mattress stores that wave around. It's the multifidi do within that tube fascia. So as you're looking here, grade one and grade two, you don't get that tensioning of the thoracolumbar fascia, which destabilizes the entire system. You think about it in reverse, somebody with a diastasis recti or a torn linea alba, they can't stabilize from the front. So they're not able to properly tension and stabilize the back because it's torn on the other side. Where here, we're not tensioning it properly in the back when we get this phase grade one and grade two, or delayed firing pattern of the multifidi doesn't then properly tension thoracolumbar fascia by filling up that space, creating tension.
So if you think about this, gets a little bit back to the Bielaski article last hour. You have this spinal reflex change, which then feeds forward into this cortical map reorganization, and then this sensory
You're
uncertainty.
right.
So you think about in the spine, they can measure this with functional resonance imaging, functional magnetic resonance imaging. You get this smudging of that mapping on the brain, and now all of a sudden you can't dissociate things. So with acute low back pain, you have this kind of dampened sensory motor cortical activity, and you also see this decreased processing of non-noxious sensory input. So just in general, the afferent for that area is going down in people with acute low back pain, and that cortical motor excitability is lowered as well. So all big, very big prime targets um, for dry needling.
Yeah, because as you saw, we look at the cortical maps that were involved in a lot of the studies with manual therapy and even dry needling. It's these, the pain pathways I won't say they're 100% exactly the same because that's never the case, but they're overlapping. And the way we modulate pain and descending inhibitory control and these things is we're using dry needling as a strong sensory input for the local tissue, but then also the central nervous system to modulate this pathway. I'm reading the title here.
So yeah, this it's a long title. This one looked at individuals with lumbar disc herniation and with chronic low back pain, and they saw that the the brain activation maps during limb movement um, was altered in those with chronic pain. So during tasks, there was kind of a diffuse and reduced activation in the primary motor cortex and the supplementary motor area. And then during resting states, there was actually heightened activity in the frontal lobe sensory area and the motor cortex. So, hey, this kind of talks about that during task, there's this inhibition, but then during the resting state, um, there's hypertonicity and extra activation of both the brain, but also the some of the muscle groups, the erector spinae.
It's kind of cool to see this because this is where the research really is for dry needling and manual therapy, and where the forefront is just in some of the brain and cortical map research. So it's always kind of interesting stuff to see.
So getting back to our case here, all right, we've done a little bit of an assessment. We see with motor control that he has delayed multifidus recruitment and decreased tone on palpation. A lot of times, oftentimes you can feel an asymmetry side to side as you palpate the multifidus. Um, you can see this, increased erector and glute recruitment. These stiffness strategies, and you'll see this when they walk in the clinic as well. The way they move is a little bit more guarded. You have them flex down, and they're going to be much more kind of almost like moving in block. Um, there's that altered flexion relaxation phenomenon you talked about. And in this case, hey, right-sided L4-5 stiffness and a little bit of mild apprehension to movement, which is not abnormal. I think most of us, when we're in acute pain, are going to have that.
Here we look at, here with this manual therapy, we have a restriction at the L4 L5 in the segment. So graded mobilizations, you can think of first one from a, a nociceptive standpoint, decrease in nociceptive improved facilitation of the multifidi, and really kind of set up the exercise program. Manipulation of L4, L5 for a biomechanical restriction is to restore the normal joint mobility and allow for that. Now, certainly there'll be neurophysiological effects with the manipulation. You also get that to a lesser degree, probably with the mobilization. But I'm still of a belief that with the articular restrictions, they are best retreated with manipulation, restore normal movement, decrease the nociceptive pattern associated with it. Because again, you would say this is an L4, L5 extension subluxation. So every time this person strides, runs, or goes into a long extension moment, does it drive the pain? Or they go to bend forward, the segment doesn't go to flex. Do you get increased flexion above or below it? Does the cortical map then know, hey, this segment doesn't flex? Let me take it from somewhere else. Let me stress another location. which is not atypical to find in most people, where you're going to find that, hey, my painful area may be the hypermobile segment that's adjacent to my hypomobile area. Dry needling plan, you know, here, one plan could be, okay, you target multifidi for facilitation. Looking to say, okay, now that we've mobilized this joint, do we see increased multifidi facilitation? Can I do, with that, with the technique to stimulate that muscle, kind of create awareness? Longissimus, like Costalis, that could be to down ramp, facilitation. I have a fascicle that's hypertonic or that's, trying to get this area to fire. Sometimes you'll even see that come up and attach to the rib, and it can create a thoracic ring rotation because I have this overactive area of, erector spinae, longissimus, ilicostalis. It's irritation. Certainly glute med firing patterns would be a common one. It's not uncommon to find trigger points in the hip and the gluteal region. So you can do glute med, and oftentimes I'm going to glute max as I do that as well. Integration with movement. We're looking at here doing dry needling as a facilitatory, maybe a precursor. Then once we allow for proper extensibility of the muscular system or proper firing pattern, we want to have activation drills occurring with that. Get this person actively moving through that joint, that muscular lengthening and contracting system. Give input to the brain and the body that, hey, it is okay for me to do this. And this is a normalized motion, is what we want to retrain the brain and the neurophysiological system. And then, as we progress on, it's going to be load progression. We want to have, after this base phase of motor activation, stability, we need to work on load progression for endurance and muscle hypertrophy. Because as we saw there in the atrophy of the multifidi, that's a big deal. That's a problem. And we need load progression to create hypertrophy of the multifidi. If we get stuck in just a phase one or phase two muscle activation phase, we may not be putting enough strain through the multifidi to re-enhance that hypertrophy.
Yeah, that's a good point. I think a lot of there's some really good work that we as PTs do with multifidi retraining phase one, phase two, but I think there's a lot left on the table if you don't really increase the loading to that and you really miss out on the hypertrophy. I had a woman earlier today who I did that at almost like exact same kind of integration. We did a little bit of manual therapy first. Her QL was a little bit toned up and erector spinae, and so we did manual therapy, we did dry needling, did some activation drills, then we did some loading with some single leg work with hinging and some pulling at the same time, and some marching with offset loads too. So you can kind of
So,
think through with this, all right, when you do dry needling, how do you layer it in? And it really comes down to what you're doing it for, I would say. But it depends on the patient a bit too. The pre-movement is going to be what we just talked about. So hey, we're going to facilitate, in this case, multifida activation, or maybe alter some excess tone of the longissimus or iliocostalis, internal, external obliques, versus, hey, post-treatment, if is there somebody with some sensitization issues, hey, let's do dry needling at the end, maybe for a cervical pain patient. Let's, decrease that sensitization and modulate the pain so that they leave you, and the last thing they leave you with is feeling better for a while.
yeah, I mean, I certainly will, sometimes use it as the ability to I can kind of do the exercise program and do things. I can reset the pain modulation after activity. So I've certainly used it that way. I've used it maybe doing some spot needling first if I need to inhibit something, and then maybe coming back on the back end and say, now I'm going to use this as a desensitization technique. We've been able to push you a little bit. Maybe you have your pain thresholds going up a bit. It's gone from a 2 to a 4 or to a 5. Now can I reset it with dry needling? It's really good to kind of get the full 360 approach. So really, when we have this program, I want to integrate dry needling, certainly early here in the scope of just seeing how it fits in the practice of orthopedic care. So we get later cases where we use specific dry needling cases on how to needle in orthopedic cares with back pain, hip, lower extremity. But I think it's good to understand this is kind of a five phase progression program. this model integrates some of the work even from Stuart McGill. So it's nice to be able to go from Paul Hodges to Joe Boloski to Stuart McGill, and include some of these, professionals and, people who have been publishing in our industry for over the last 30 years. Five-phase progression program, pain reduction, injury control is phase one. Basic stabilization, progression of motor control, phase two. Endurance work of the muscular system is phase three, which gets into that, rehypertrophying the multifidi. Certainly, phase four is rehypertrophy of the multifidi and strength and normalizing movement patterns for daily activities. Phase five, many times we don't get back into, that's really that return to sport and high level function, most people. And, dry needling and manual therapy has relevance through these. As you'll see, your phase one, phase two, probably going to be a lot more of in that early control. And you may find that your manual techniques taper off as you get into later, unless you're really looking at this as being part of a recovery strategy. Classic phase one exercises here we included, you have your transverse abdominis for injury called TA activation, trying to get the right muscles to fire in the right timing sequence and creating that conscious connection. So diaphragmatic breathing and core engagement is often a big one of, can I disassociate core bracing and diaphragmatic breathing? For many people with lower back pain, this is an issue. We can't quite normalize this pattern. So working through this. Pelvic floor activation with TA contraction. Pelvic floor fires like almost like I believe a split moment before the TA does. So sometimes our TA contraction patterns can also be pelvic floor issues. So we want to look to get somewhere where we can get that deep system facilitated. Supine heel slides with TA activation is another easy one. And supine marching can be used in some cases. Everyone has a little different strategies. These are just some simple examples of what might be in that injury reduction pain reduction injury control section. Basic stabilization. We think quadruped abdominal bracing, our dead bugs with TA activation, bridge for core control, sideline clamshells for core engagement, with core engagement is the focus of that. So think the clamshell, not so much focused on glute med. We need a stable core for the glute med to activate properly. So many times when you do your hip abduction test and you find, oh, I have weak hip abductors, the next thing I think of, which one of the five things which can create a weak hip abduction do I need to check? SI joint stability, pelvic stability, multifidi, TA firing activation timing, hip, sublux tip. All these things can create inhibition of hip abduction. So again, remember, you do your hip abduction test, and next time you come up with weak glutes, think of what are one of the 5 or 6 things that would inhibit the system or create failed load transfer through it first. Standing core activation with arm movements is another kind of basic stabilization firing mechanism activity we have in a phase 2 rehab program. And remember, the dead bug is popular as it is, much like with the bird dog. It's really good at getting muscles to activate. None of these exercises within themselves create hypertrophy of the multifidi. Endurance training. This may be endurance planking with a transverse abdominis focus. And sometimes it's not doing maybe 3 minutes of planking. I think you'll see like Stuart McGill's work is often 10 seconds of focused abdominal planking with resting before you transfer that load to the inert tissues, which would be facet joints, ligaments, disc, leg lowering progressions from tabletop position, side planking from knees, standing weight shifts with core engagement. And they have hip hinging with core bracing, side plank clamshells, other core engagement. I mean, you also saw in there that, the Australians and Richardson Hodges, they used the body blade a lot for this. So they used oscillatory mechanisms as well in their research. So body blade is a good endurance one. Palloff press with holds can be a good endurance exercise. These are just 6 examples. There are hours of things that may fit in this subcategory, and you may find that your patient will be blending phase 3 exercises with phase 1 or phase 2. You'll often blend these exercises in any program.
Yeah, oftentimes I see that there's a lot of blending. Hey, multifidus is not activating, but abdominals are good, so you can kind of skip around a bit. So then phase 4 is when we really get into this, much more of the hypertrophy phase. And again, this is not an exhaustive list, and all of these things can be progressed and regressed with weights and different mechanical changes. You get into the single leg bridges, you can put some weights or some sandbags on the hips. Um, Step ups with core activation, hey, maybe with an offset weight in the opposite hand. You get that into the bird dog with some core control, and then you can progress the bird dog. I like to do, hold a bird dog position on up on a table or a bench and do a row with the other hand with a weight, or a banded press. Um, you can get into the whole split stance cable work. You can do a, press. You can do row, flexion, horizontal abduction, and then some standing lateral band walks as well.
I mean, ILEX training is one thing they've talked about more recently too, which is basically it's resisted extension, like using extension machines and holds. They found that because it hypertrophies the multifidi is what they see with that as well. It's kind of based on a study that was done a number of years ago now, where they looked at east concentric exercises, like at back extensions versus 10-second holds, right? Going into a back extension and holding for 10 seconds. They found that the back extension with 10-second holds hypertrophied the multifidi better than the concentric, flexion and extension exercises. So some of that ILEX work where it's that sustained back holding with extension machine training has shown some hypertrophy. So there's some decent things with there. And you'll see, I think Joel Cook, but Chad Cook has talked about that in some of his work. Return to sport, here you're looking at much more dynamic loading activity. So your single day leg deadlifts, and I would say that this would be with a decent amount of weight. Kettlebell farmer carries with heavy resistance, dynamic lunges with overhead reach, medicine ball rotation throws, side plank with arm reach forward and backward, or some examples. I've often sometimes what you'll need to use if they're an athlete is you need to get the heart rate up. So some of my strategy then might be doing some biking or aerobic work, then followed by core exercises. So I might incorporate some of my phase 3 work with my aerobic exercise. Sprints on the treadmill. That's me. Let me come off and do my planking or some of my leg lowering exercises. Can the system then disassociate the breathing pattern when the respiratory rate is upping? Can I control breathing and can I control the core? Because in some of these athletes, that'll be some of the failing pattern is that they're doing great, but as soon as they get up there and their respiratory rate and the demand level goes up, then the back stabilization system starts to fail. So for the athlete, the need is a little bit different in that they need to be able to manage the respiratory demands of physical activity, coupled with lumbar stabilization. So their program should take that into account. Movement retraining sequences, activation, motor control exercises, your integration. You can look at bird dogs, your bridges, your mid-level stuff. Again, functional stuff is hip hinges, single leg tasks. So there's a simplified version or talking about the whole model we just went through with the Stuart McGill kind of 5-phase model.
Another way to think about it is, first you have to learn how to do the pattern of the movement. Next is you add some load on top. Then you make it asymmetrical, so doing some one leg, single leg task. And then finally would be that kind of return to sport, which would be that explosive. So, hey, you're gonna do some med ball throws, you're gonna do some change direction drills, integrating all these things, but all of them have to be there in order to progress to the next one.
Anything we want to see here in the short-term outcome, what we expect is short-term, we want to see decreased tone and improved facilitation of the proper muscles, deep multifidi, proper sequencing, glute before hamstring with loading activities. Midterm, we're looking at increased control, decreased recurrence of pain. And here it's good we have, different measures, NPRS scores, the ODI. And again, ultrasound multifidus ratio is another good one that's included in there.
Again, with that hybrid model from Hodges, I think it's good to use that start back as a prognostic, a little bit of a guide, not a diagnostic. So for this case, a 35-year-old male, all right, he had medium risk with the start back tool. The mechanism is more of a movement driver. So we did some adjuncts, we did some manual therapy, we did some dry needling, and then the follow-up, which again is crucial, is that education and load. So, um, you know, education in terms of maybe some sustained positions and how he moves at home and at work or with his sport. And then the loading key is piece is all right, once we have the activation, make sure we add the appropriate load to stimulate hypertrophy to again in terms of the multifidi, really preventing that fatty infiltration is crucial.
Okay, evidence and limitations, hybrid model. It's kind of a conceptual, it's just a concept model of integration of, not following one pathway or the other, using that clinical reasoning model. And where does the start back tool possibly fit into that clinical reasoning model? Manual therapy, understanding manual therapy. Yes, there's neurophysiological benefits to manual therapy and there's biomechanical. So I'm blending in the biomechanical approach of, say, joint manipulation, mobilization with the neurophysiological model, which is we get similar effects with manual therapy, but also dry needling and being able to really interact in the nervous system in a clean, efficient fashion. And it's been kind of there's a large body of research kind of supporting it now. And certainly when you pull the research that's been brought over from China as well as the US, just the neurophysiological mechanisms there are just well supported. Dry needling is certainly an adjunct to create a window of opportunity in your therapy sessions. Dry needling has been shown to improve, short-term patient outcomes with pain modulation. And what we want to do is to be able to create this window of opportunity and plasticity so that we can fix whatever the primary driver is in their pain pattern, get them on their way. Again, certainly, in our world, there's always a need for integrated, random control trials and studies. Random controlled trials and studies certainly have their limitation in the PT world and kind of proving what we do. Probably even some other better study, other ways to do it out there, but it's always nice if you can get them.
I think the big thing, there's some takeaways. I think, start playing around with the start back tool. A lot of times, as we said, you can get a sense of the people who are the high risk. You can usually pick that up just in talking to them and observing. But using that start back tool for prognostics, really get into the mechanism, neuropathic, nociceptive, or central sensitization, and then beyond that, is it a biomechanical or a pathoanatomical? Apply that manual therapy and the dry needling, retrain the movement, and then reassess. Pick your test, whether it's in our case, hey, maybe it was some flexion movements that were guarded. All right, do the treatment, manual therapy, dry needling, do some retraining, and then reassess.
Takeaways we have, start back tool is really a triage tool just to get a sense of, okay, where might you fall in this continuum, knowing that your situation may certainly change. Manual therapy and dry needling, it really creates this facilitators, this window of opportunity to down ramp or down regulate the pain so that you can kind of progress a more active treatment profile and program. Know that, hey, these are really good at, decreasing, short-term pain outcomes while you fix the problem. Hybrid integration models, it's that clinical reasoning model, keeping your mind open to what best fits for this individual. They may start off in a flexion-based program because they have a flexion-based pain-driven model, but then they need to become more dynamic. It needs to become more stability. I need to pull in the work of Hodges and look at, okay, do I have multiply inhibition? You know, do I have extensibility of hamstrings and thoracic spine? So really, we look at this clinical reasoning model that integrates multiple approaches. In movement retraining in our world biomechanically, that's some of the most important thing in long-term fix. Can we identify the aberrant pattern? And can we retrain it so that the facilitated tissues are less facilitated and the inhibited and weakened tissues have proper tone? Good. That kind of concludes it. Here's kind of the main references of what we used in this presentation as well. All right, great. We finished this hour session here. I think we're good and we're moving on to the next one.